Unfortunately, if you notice from the program, we don't have a third panelist. We tried hard to get a representative from Mexico to present their position on this very important topic, but unfortunately, just due to a number of different circumstances and not timing and just everything else, it didn't work out. So unfortunately, that perspective will not be provided on this panel. But I did want to let you know that we did try to include that in the panel. It's my pleasure here again to be chairing this important panel. My name is Rick Kilroy. I'm at the Virginia Military Institute. And prior to that, I was on active duty in the military and involved with NORTHCOM, the stand-up after 9/11, and some of the issues related to Homeland Security. And one of them specifically dealt with this issue of pandemic flu. In fact, a conference in San Antonio in 2006, sponsored by NORTHCOM, University of Texas San Antonio, and my former school, East Carolina University, dealt with how communities would deal with some of these types of issues, which led to the development of things like pandemic flu plans and emergency preparedness for this type of situation, which we did in fact experience just recently. And so our panel is very timely in the sense that it shows one of these areas of cooperation between our three countries. I'm very happy to have Dr. Alex Garza with us today from the Department of Homeland Security. As you can see from his bio and his background, he has a medical background, he has a military background, he has a policy background. I think he's probably got everybody trumped here in this room in terms of the breadth of his experience and what he brings to our panel, so we're very happy to have him here. We have also Dr. René Engelhardt from the Public Health Agency in Canada, and he also has a very diverse background in both academia and now in the policy practitioner world as well. So we have a very good panel, even though we only have two speakers from those two countries. And then our discussion for the panel is going to be Ian Brody. And Ian and I shared a little bit about our concern about our lack of familiarity with this subject, but like anything else in academia, why would that stop us? And so we decided to go ahead and press forward with chairing and discussing this panel. And as I explained that you see his background currently having been in academia, but then also working for Prime Minister Harper's office, and now he works for consulting with the Inter-American Development Bank. And we didn't stay at a Holiday Inn Express last night, but we'll do our best to try to contribute to this discussion as well. So thank you all for coming. And Dr. Garza, I'll turn it over to you.
Good afternoon, everyone. I want to thank you for the opportunity to speak here today, and on behalf of Secretary Napolitano, welcome. I'm going to briefly share with you, first of all, what an Office of Health Affairs does within the Department of Homeland Security, since I seem to get that question quite a bit, and discuss the importance of public safety and health collaboration in a governmental context. So first, let me share a little bit about my office. The DHS vision writ large is a secure America, a confident public, and a strong and resilient society and economy. At the Office of Health Affairs, our mission is to provide medical, health, and scientific expertise in support of that mission. And that is to prepare for, respond to, and recover from any sort of threat that would impact the security of the country. So early on in the decade, the Secretary of Homeland Security realized that in the midst of a tabletop exercise, when he had to turn to somebody and ask, what do I do? And it was a medical situation, that nobody was there to answer the question. And so he said, I need somebody on my team that can answer the question. And so the Chief Medical Officer, which is what I represent, was created then. Furthermore, the Congress and subsequently they recognized that there are a lot more issues surrounding health and security than merely just giving advice to the Secretary, and so they created the Office of Health Affairs. And so it was really rather wise of them to start going down this path. As I preach to our troops and to people out in the public, you really can't have national security without health security. The two are inextricably intertwined. The example that I use is that if a building were to fall down here in the middle of Washington, D.C., it would be 30 seconds probably on YouTube. If you add one person into it, then it's a disaster, and then it becomes a big story. So the element in that is that human health does matter. So within OHA, we do a couple of major missions. The first and foremost is to advise the Secretary on all of the issues with public health, and as the example that Rick used earlier, that included H1N1, which consumed a large amount of our time in the spring, summer, fall, winter, we seem to get a lot of face time with the Secretary this year, or past year. Secondly, we lead the department's workforce protection. So like the military, we do have a large operational force that we need to make sure can show up to work every day to guard our borders, to look at our containers, to fulfill our immigration laws, things like this. Next, we provide medical and scientific expertise in our preparedness and response efforts, whether that's at the policy level throughout the U.S. government or planning efforts down into the state and local levels. And last, we have a fairly robust biodefense and weapons of mass destruction division, which we do a couple of efforts that I'll share with you later on in the talk. So in order for OHA as well as DHS in general to achieve success, our office has to interact what I call horizontally and vertically. We have to operate with our other interagency partners, and we also have to operate from the local level to the state level to the national level and at the international levels. Really, Department of Homeland Security, when you get down to the nitty-gritty, is all about cooperation. We have to cooperate with people in order to have a successful defense and security strategy. So we have to strengthen and build these partnerships to maximize, and we maximize this through using science, technology, and innovation, and to leverage those resources and become more efficient. So that was in brief what OHA and how we fit into the greater mission of Homeland Security. So now I want to move on to our past, present, and future planning efforts for pandemic influenza, and how this can be used as a template for how we can use this looking forward into other events such as bioterrorism or other forms of health threats. The National Pan-Flu Plan implementation plan was developed by the White House and addressed much more than what we can do specifically applied towards influenza. The plan addressed general emergency management and included such things as how the federal government will use all instruments of their national power, how the states and communities can have credible preparedness plans, how the private sector should play an integral role, how individual citizens can be educated and how they can individually become resilient, and how our global partnerships can be leveraged. So the millions of dollars that we spent in the United States on pandemic influenza, as well as the substantial sums that were spent in Canada and Mexico, did more than just plan for pandemic influenza. They helped lay the groundwork for future events. And so although all the plans were made for a very severe influenza, they served very well in adjusting them for what turned out to be a not as severe but still a globally pandemic influenza. So whether it's in the face of nature or in an act of terrorism, we're in fact becoming better prepared and more resilient because of the groundwork that we had laid in the pan-flu plans. So it's important to remember as well, and I think we were alluding to this before, is that biological and infectious disease and diseases of health threats are a lot different than the conventional forms of terrorism, and that is that there usually isn't a single episode that defines the incident. As we saw in H1N1, it was across borders before we realized what was going on. And it's not like you can stop influenza or a biological agent at the border. They're ubiquitous in society, they travel very easily. And so these aspects make it a very different actor than your conventional forms of terrorism or health threats. So alongside our national strategies for pandemic preparedness, international cooperation is equally important. The 2009 H1N1 influenza, I think, was a very good exercise in how we can leverage our relationships with each other, especially here in North America. The things that we brought to bear to the fight were such things as laboratory expertise, epidemiological tools, antiviral medications, personal protective equipment, and recommendations on social distancing. So a lot of those revolved around public health. Where we took a different tact at Homeland Security is we also have to figure how do these elements play into a national security posture. And so a lot of those elements surrounded issues like, do we need to close the borders? Realizing that that is a very big impact on commerce. And so recommending to the Secretary, using the best science that we had, that well, first of all, it was already in the United States, so it didn't really matter. But explaining and walking that through for the Secretary that even if we close the borders, it's not going to stop the spread of the disease. But what it will do is it will inhibit commerce between our two countries, which is huge. And another issue that we tackled quite frequently was travel advisories. Travel advisories and screening of passengers coming on and off international flights. And we quickly realized that that was not going to be very fruitful as well. Again, using the best science available. In fact, our Canadian partners did a large amount of work on passenger screening that really added to the body of knowledge. But bringing that sort of expertise to the policymakers so that they can make informed decisions that even though it's a health factor, it's going to have second and third order effects that affect the rest of the country, that affect the security and the commerce of our country. So it's very important to take these things into consideration. So additionally, on October 5th of 2009, Deputy Secretary Jane Hall-Lute led a U.S. delegation to Mexico City to participate in trilateral discussions with Canada and Mexico. We had representatives of Public Safety Canada, the Secretary of Governance Mexico, the foreign ministries, the health ministries, and the agricultural ministries from all three countries. It was a wonderful conference. While the discussion was obviously about a health topic, it also focused on how our three countries could collaborate to better protect ourselves and our people from the harmful impacts of the areas of society not usually considered in health discussions. To build our global resilience, we need to continue to build our international health organizations, which includes my office, in the ability to respond rapidly to outbreaks and help countries at risk strengthen their abilities to prevent, respond to, and recover from suspected outbreaks. And working together as much as we can will allow us to leverage what each of us brings to the fight and to learn from our pandemic planning for our future threats such as bioterrorism. Next, I would like to offer a few thoughts about things moving into the future. As I mentioned earlier, OHA is responsible for the Department's biological and chemical defense activities. And if you have read the WMD Commission report from the United States WMD Commission, they value or they place bio very high on the list of threats that will potentially impact the United States in the near future. So we run a couple of programs within our office specifically to counter these threats, and one is called our BioWatch program. BioWatch program is the only federally funded, or federally managed, it is funded as well through the feds, locally operated nationwide to detect select biologic agents. It operates in high-threat metropolitan areas, but the beauty of it is it's incorporated down to the state and local levels. And the goal is early detection so that we can employ countermeasures as quickly as possible once a detection has been made of a biological agent. So it's absolutely critical for the successful treatment of the affected population. And if we're to believe the projections are true, it can potentially save thousands of lives. So we take this charge very seriously. As I said before, biological attacks are much different than the conventional explosive, including nuclear or even chemical attacks, where usually detection is much quicker. Faster detection equals a faster response, which equals lives saved. Another component within our office is the National Biosurveillance Integration System, or the NBIS. What this is we've taken a look at biosurveillance data, and we came to the conclusion that we need more data than just health data. We need to start integrating other forms of data, looking at other ways to tackle problems which could impact security to the country. The information sharing allows us to evaluate, to develop early cueing, and to better inform our decision makers while they're in the heat of the battle. So looking at other disparate forms of data, such as from transportation, shipping data, even data during the flu, looking at our educational absenteeism helped us predict which way the flu was turning. So this was an important initiative that was started a couple of years ago that we're starting to see some benefits from, as well as some forecasting ability, which we're leveraging our relationships with our national labs to try and give our decision makers an idea of what things are going to look like down the road so we can prepare for them. So I think a biosurveillance, and even above and beyond just the health surveillance, is going to be crucial for our three countries in the future. So in conclusion, I'd like to emphasize that we can apply so much of what we learned during pandemic planning to our bioterrorism and, frankly, any sort of health threat planning. I want to remind you that we all live in a new threat environment which throws new challenges at us all the time. As Dr. Jolly and I were discussing on our way down here, there's just too much time, and in addition to all this stuff that we have to get done on a routine basis, it seems like we're always thrown a curveball that we have to deal with on an emergent basis, such as earthquakes in Haiti, such as H1N1, such as other things going on. And so we have to have the systems in place in order for us to execute properly. I truly believe that continuing to build this trilateral relationship to facilitate information flow as well as other resources is going to be key to providing a robust defense and security for our three countries. And I want to charge us to participate even more in the preparedness and planning issues, so that we can identify whatever gaps there are, identify best practices, so that we can bring to bear all of the issues, all of the preparedness activities that we can to protect each other. And it's really only through these partnerships that we're going to improve. So again, we must not focus not only on what we've already experienced, but also to those that we consider remote possibilities. By learning what we experienced, like H1N1, and applying it to our potential threats, like bioterrorism, we'll become more resilient as nations and as as well as add to global security. So again, I want to thank you again for inviting us to speak here. I very much appreciate the opportunity to discuss health and health security. And again, we'd be happy to entertain any questions later on. And if there are any particular questions for my office, our email address is healthaffairs, all one word, @dhs.gov. Thank you very much.
Thank you, sir. Appreciate it. I just want to thank Dr. Garza again for coming. Unfortunately, he is going to have to slip out, but he did bring with him Dr. Till Jolly, who was also from the same office, and he will be here for our question and answer at the end. So if you have any comments that you'd like to follow up on with Dr. Garza's presentation. Okay, and I think with that, I'll go ahead and turn it over to Dr. Engelhardt. Thanks. Okay.
Thank you. Is this somebody's?
It's through time.
Okay. All right, so what I'd like to do, first of all, ladies and gentlemen, thank you very much, and thank you for the invitation to be here on the panel. It's a pleasure to do that. What I'd like to do is talk about public safety and health cooperation from the Canadian perspective. I'm going to decrease the discussion of the H1N1 pandemic a little bit, a little less, since Dr. Garza had given really good overview of what had gone on at that time, and stress a little bit more the way public health safety and really health security is practiced in Canada, but with an emphasis on the sharing, the cooperation in a trilateral sense. So very briefly, I'll go through what the agency is about and focus then, as I said, on the cooperation side. The Public Health Agency of Canada, first of all, for those of you who are not familiar with that, is an agency of Canada, independent. It is headed by the Minister of Health and headed by the Chief Public Health Officer, and it has a multitude of branches, and I'm really only putting that on there to indicate that a fairly large proportion of the agency specifically engages in cooperative activities and health security related activities, and those are the ones that are highlighted in red on that slide. It has a legislative mandate in Canada. Some of that also relates to health security, and in particular the Quarantine Act, which allows Canadian forces or Canadian enforcers, in that sense, I suppose, to have detection and detention at borders of individuals who are deemed to be infected in some way or of ill health. Also the Human Pathogens and Toxics Act, which is new, specifically affects the transfer and transport of pathogens, which has security issues associated with it. In fact, though, the sort of integrated response in Canada with respect to public health and security was not very well integrated until the 9/11 and additionally the anthrax attacks and the SARS events. Only then really did Canada come to realize that it needed a national security policy, and that was put in place in 2004. And it has a broad range. It deals with public health emergencies of all sorts, not just infectious disease, chemical, biological, radiological, and nuclear threats, and included in that, of course, are bio threats, biological weapon threats. In all of that, the Public Health Agency of Canada is only one player of many of the agencies in Canada. As you can see on the left side, most of the federal departments of Canada are involved, but the lead organizing department for from a safety and governance perspective is public safety in Canada. And then we're linked into the various stakeholders, as Dr. Garza also indicated, in a response scenario with academia, with private sector, et cetera, as well as the international stakeholders in that. If it is a health emergency, health-related emergency, this is where the Public Health Agency of Canada is particularly engaged and has the operational lead for a response. And this complex diagram shows you really what happens in Canada. Centrally, the Public Safety Agency is core to coordinating all of the federal activities, the various departments, including Food Inspection Agency, Environment Canada, Defence, certainly, Department of Foreign Affairs. But it's left to the Public Health Agency and its Centre for Environmental Protection and Response that to manage the actual response activity from that health perspective. It does it through an EOC, which is the HP or Health Portfolio EOC, Emergency Operations Center. And that Emergency Operations Center, by the way, has embedded into its staff people from the U.S., from the U.S. Health Services, as well as from Mexico. So they're always there, and they also become activated at the time of an actual emergency. And those EOCs, the Health Portfolio EOC, is supported by public health agencies' laboratories, such as the National Microbiological Laboratory, which has its own smaller EOC that is fully integrated with the main one. And it's that National Microbiology Laboratory that has ongoing interactions with laboratories throughout the U.S., throughout Mexico, in the U.S., in Mexico, and throughout the world as well, but with special relationships that are long-standing relationships with the CDC. Okay? And if it happens to be a foodborne zoonotic outbreak, whether it's Listeria or Salmonella or what have you, then the other Emergency Operations Center, which is located in a different setting and has different expertise to back it up, it does a similar function as does the National Microbiology Center. So, in the context of the national security policy in Canada, public health security is really fully integrated as an approach, as a matter of policy. When you look on the left side of the slide, the integrated national security system, the Canadian one, has sort of the four main elements that guides it: threat assessment, protection and prevention, consequence management, evaluation, oversight. The same approach is used in the public health system response. Okay? So that they're really mirrored entirely. So it becomes relatively seamless when the emergency is one of public health, a pandemic, such as an H1N1. A little bit more emphasis on what does it mean as far as the public health agency is concerned. And when I go through these are activities and capacities that are actually certainly located within Canada, but are integrated with our U.S. counterparts and our Mexico counterparts. With respect to preparedness, there's lots of applied and discovery research that goes on, especially in infectious disease. R&D on countermeasures, contracts with vaccine manufacturers. That was very evident in the last H1N1 pandemic, that had to be activated to provide a domestic supply. And there is now a Canadian pandemic influenza plan for the health sector that's coordinated, that's similar to the North American pandemic influenza plan. There's an extensive, I'm not going to go through every point on here, just to say there's an extensive surveillance and epidemiological capacity resident within the Public Health Agency, as well as the provinces and territories that Canada interacts with. The individual provinces and territories also have, obviously, their own health departments, but also have a emergency response capacity and centers for disease control, whether it's in British Columbia or in Nova Scotia. Further, there is a service capacity. In the scenario of a public health emergency, the laboratories that have a strong research base and research background flip almost entirely to it being a service function, to serve that emergency response by having activated their level 3, level 2, 3, or even 4 level laboratories to support the emergency response. They're connected in the Canadian Public Health Laboratory Network that links, as I said, to the provinces and territories, and they link the same way on the international side. They are members of PulseNet International, which is a US-derived information system, and are a national reference laboratory, very essential in the characterization of a disease outbreak. From a more physical perspective, there is a response capacity in assets. There's a $300 million National Emergency Stockpile System, a NES, that's been around for close to 20 years now. A National Office of their response teams in 2 sets, health emergency response teams of a national nature. There are operation centers, as I said, and there are also mobile emergency response teams and laboratories. The Winter Games in Vancouver had 2 of the Public Health Agency's mobile laboratories on site to do both baselining, background work, framing basically against a potential outbreak, and then to be ready to actually be activated in an outbreak scenario. And so, as I said, there's a nationwide network that gets activated as well. There we go. Now, on a cooperation basis, Canada, I think, one could say, has a long-standing relationship with the World Health Organization in public health, and that's managed through a whole series of networks, understandings that go from mutual assistance to laboratory information exchange, of sharing laboratory practices, and so forth. That it is really pretty extensive, and certainly Canada, as the U.S., as Mexico, are really report under the international health regulations if there is an outbreak of any international concern. Canada, along with the U.S. and Mexico, are interactive with the Pan American Health Organization through antimicrobial resistance surveillance. We also participate with the Caribbean Public Health Agency, and a recent example is the Haiti response. The agency had a small contingent of advisors in Haiti, which were logistically supported by the U.S. on site and coordinated through PAHO. And there are other examples that sort of are not as major as the H1N1 or the Haiti event. On international relations as well, we're members or participated in the Global Health Security Initiative, and are members of the Global Health Security Action Group, which really is, it's all focused, along with the U.S., along with Mexico and other countries, to share information, to have a capacity to respond on an international basis, to trial in events ahead of time, in other words, practice the art, as it were, of emergency response. But most important, they're really there for information sharing and technical assistance, and also policy making on an international basis. A couple of specifics: Canada, U.S., Mexico cooperation on health and security was identified as one of the 3 priorities in the 2009 North American Leaders Summit. Canada is certainly fully responsive to that. We engage, as was mentioned in the course of today, in both bilateral and trilateral cooperation. And that altogether certainly promotes a North American approach to security and public health threats, strengthens our cross-border coordination, and importantly fosters a greater understanding of each other's national security priorities. And bioterrorism is certainly woven throughout all that. There are some implementation agreements that guide that cooperation for Canada and the 3 partners. The Declaration of Mutual Aid Assistance during a public health emergency guides the three of us. And there are several examples that relate to that, where that was implemented. Winter Olympics, the exchanges of the public health liaison officers I just talked about, deployment of the supplies, in our case from NES, in one example, in the Hurricane Katrina event, and diagnostic and training support in Mexico at this time. There are agreements between PulseNet Canada and PulseNet USA, and that's for a seamless integration of information sharing, and that assists certainly in more rapid outbreak mitigation. And there's an agreement between Canada and Mexico, ministers of health, medical officers of health, a network of public health intelligence, and here there again, CNPHI is an information sharing system, and it is being developed to have a similar capacity established in Mexico now, in the Spanish language. And there are a multitude of other cooperation activities that are existing, that are being practiced, that strengthen that trilateral relationship and trilateral security in public health in North America. And the H1N1 example was a test case for what we had been building thus far. And I think it ended up, it's fair to say that I think it ended up being a success from a pandemic control perspective. There are certainly lessons learned from it that suggest that our next pandemic response, a trilateral pandemic response, will be even smoother. And just to conclude here, I think this is going to be a little bit repetitive from what we've said over the course of the day, but certainly there are challenges on trilateral cooperation. There's a balance between the sovereignty and interdependency, from shifting from national security to continental security. I must say, however, that, at least in a personal opinion, that is less of an issue when you're dealing with a public health threat. Just as Dr. Garza said, the bugs don't care about borders. And so it is very easy, actually, to declare that, yes, you've got the same problem on each side of the borders that are there. And that makes integration of a cooperative response and information sharing, frankly, much easier than maybe in other areas of cooperation. And it's easy to overcome the differences. Not easy. One needs to overcome the differences in governance and legislation and regulations. And to help with that, we basically develop common principles, common best practices, networks and networks of networks, sharing of expertise and experiences. And again, perhaps in the health side, that is facilitated almost at the grassroots level, because our scientists, our physicians, our even healthcare workers in the US, in Canada, in Mexico, typically will have been interacting on a professional collegial level anyhow. So there's nothing that makes, I think, makes cooperation work most quickly in times of duress than when you've already got a personal relationship established. And that does help in this instance. And the benefits, certainly, of trilateral cooperation have become fairly evident. Increased preparedness, increased rapid response capacity in each country and for all three countries. And that promotes the alliances and partnerships. And actually, we are able to provide a North American-wide perspective more globally as well. So we have a brief mention this morning about how do you translate trilateral security cooperation in a global context. When you're dealing with pandemic threats, the global context becomes important. And so if an outbreak is detected by a country in Southwest Asia, of course I'm thinking of the H5N1 avian flu, it is critically important that we as Canada, we as US, and we as Mexico receive that information as soon as possible. And frankly, it doesn't matter who receives it first. If we've got a well-established trilateral information exchange, we should all receive it basically simultaneously. And that type of cooperation becomes critical for an effective and early pandemic response. So I think that's really what I wanted to say, and I'm looking forward to your questions. Thank you.
Rick, let me just say in relation to you and I being the amateurs of this operation, have PhD will travel. I should emphasize that despite the various institutional affiliations listed on my bio there, the views I'm going to express today are my own views, not necessarily the views of my current employer, and certainly not necessarily the views of my former employer. But I will try to make sure that what I say is informed by what I learned from both my current employer and my former employer. Because almost everything I know about the little that I know about this subject comes from the trilateral political context. And maybe I could just reflect over the course of the material we've covered today on my 3 years of cross-border and cross-border work on this. My work in the Prime Minister's office had, unfortunately, from time to time, a defense side to it. Unfortunately, because it was, it's never good news. But the trilateral relationship that's emerging on the defense side is informed by a very strong bilateral defense relationship and binational relationship between Canada and the United States, blossoming bilateral relationships between the United States and Canada on the one side and Mexico on the other side. And so there's a strong bottom-up nature to the evolving trinational cooperation. On police and law enforcement, similarly, there's no binational institution for managing law enforcement and police cooperation between the three countries, but there are strong bilateral relationships at a professional level in order to manage law enforcement threats across the borders of the three countries. Whatever's going on at the continental level, the trinational level, is again a bottom-up process of learning, of relationship building, and at some point perhaps of institutionalization. On the health side, things are quite different. My experience was that the developments at the trinational level are quite different. Why? Not because there's any lack of bilateral relations, but because, as our two presenters mentioned, the North American piece of international public health is a relatively small part of an international public health system. World Health Organization, PAHO, in this hemisphere have been far ahead of the trilateral developments. The trilateral security issues here are a small part of a multilateral world that's well managed by extraordinarily strong technical, professional, and political connections that go far beyond North America. In this context, in all the discussions we had at the political level, I noticed there were very few truly trilateral public health problems to tackle. What there were North American manifestations of global public health problems. H1N1 happened to first be alerted to, North America first managed in the North American context, but rapidly became a multilateral global health issue. And the proof of that, I think, is in the public communications surrounding the outbreak of the H1N1 pandemic. There were strong national communications efforts by governments in Mexico, the United States, and Canada in order to communicate to their national populations about the consequences of this outbreak. And then a truly multinational communications effort from the World Health Organization. But I don't recall that there was ever a concerted trinational effort to try to do public communications effort regarding this, nor would there have had to have been. To try to invent an institution that would have allowed that to go on would have been really a true duplication of effort and sort of missing the mark entirely. So whatever evolving and continues to evolve post H1N1 trilateral efforts there are here are facilitated tremendously by extraordinarily competent international multinational efforts. This leads to my question, going back to my involvement with the, are we allowed to say SPP anymore, Rick? Yeah, the SPP, the North American Leaders Summit, and the high-level discussions. During the course of the 3 North American Leaders Summits that I was involved with, 2 in person and 1 in the preparations for, I can say there was a vast amount of resources poured into North American level public health cooperation and a tremendous amount of time, even between national leaders, in working out the arrangements that discussed at the various North American leaders summits to try to prepare for pandemic flu and other common international health problems public health problems that might affect North America. The Guadalajara summit came too soon to step back, I think, really, and ask what parts of that were worth it. It struck me that for all of the money that was authorized by the 3 countries to lay the groundwork for this, the most important message that came certainly from the 3 national public health authorities was you should wash your hands more frequently in order to help combat this thing. And by far the most important thing that you can do is to wash your hands very frequently. There's all sorts of other things going on, but the most important thing we should talk about publicly is the absolute imperative to wash your hands as frequently as possible. And by the way, if you think you're washing your hands frequently enough, you're not. Please wash your hands at least 3 times as frequently as you think is frequent. If that's the most important thing that can be done in terms of managing the ground level impact here, the $300 million for stockpiles, the $300 million for building up virus typing capacity, the $300 million for standby vaccine capacity, and so on and so forth, was that the most cost-effective thing? I think it's going to take, by the way, I ask these questions, I assume this is at least a 3-year process to understand this, because we need a little bit of time. Professor Wang.
Well, thank you, Professor Brody. We've got a lot of time to ask questions on this panel, so we hope that you will join in, and we'll go ahead and open up that. Just again, we just ask you to wait for the microphone if you do have a question. And please identify yourself also. Thank you.
Well, first, thanks very much for the talks. It was very interesting. My name is Andre LaPrairie. I'm with the Public Health Agency of Canada. And as Dr. Engelhardt pointed out, I'm one of the liaison officers that's down here embedded in Washington. And I wanted to pick up on a point that both Dr. Garza and Dr. Engelhardt had made, and that was early on it was recognized that any kind of border strategy would not work. You know, pathogens don't have passports, and it wasn't just the infected countries, but there were no travel advisories issued by WHO. So to have a strategy that's only within your country would seem to be non-effective. And yet many of the strategies and many of the decisions that we made were very siloed. The decision around to add adjuvant or not add adjuvant, to close schools or not close schools, to delay seasonal flu shots. Even the sharing of surplus vaccine was not well coordinated. And right now we have lots of surplus vaccine. We can't give it away, let alone sell it. So certainly in this past experience, there didn't seem to be a lot of collaboration, trilaterally or otherwise. And I'm wondering if there are plans to do that better, because right now a lot of the criticisms we see, I think they're baseless on the WHO, where they talk about how it's in the pockets of pharma. It's not true, but at the same time it appears that way, because we'll keep spending the money on vaccines, and yet much like the corner grocer who keeps paying protection money to the mafia, it doesn't go away, it just keeps spending money. So if you really want to have an effective strategy against, in this case, H1N1, but I think any international health challenge, where are those focal points where you're going to have those strategies? Where are we going to talk about, maybe vaccine supplies that aren't limited by borders?
Did you want to address something?
Go ahead. Well, I think I'm going to try and respond to your question, perhaps a little bit obliquely, but I'll preface it by saying that I think we were lucky that the particular biology of that H1N1 virus had 2 elements. One is that it was not highly virulent. It affected certain populations more serious than others, but frankly it was not as, from all the records, although Ian's point should preface with that, necessary to say that it'll probably take 3 years before we truly understand exactly what happened. But thus far, the indications are that virus was not as virulent. It was, however, highly infective. It spread throughout the population extensively, so that we can say now that 90%, over 90% of Canadians that actually reported that they had the flu over the past half year are positive for H1N1. Okay? which is saying both. It's not highly virulent, but it's also very spreadable. We could easily have played the game, a war game, that says, what if we had a really virulent, high-spreading virus? Probably the impact would have been much, much more serious. So we were given a reprieve, I suppose, to test a system of response, an integrated response system, that had a bunch of warts and hairs that we worked through. And some of that was siloing, some of that was not having ground truth, basically, the delivery system for vaccines, having problems in vaccine delivery with respect to its timeliness in Canada as well as in the US. Questions about how much of the population should you really be vaccinating when push came to shove, even though, at least I'll say in Canada, the contract requirement for vaccine delivery was that enough capacity to vaccinate every citizen in the country. But then other questions came through. Did you need 2 doses of vaccine or only 1? It was, as you said, Andre, the adjuvanted versus the non-adjuvanted. And there are many elements like that. Overall, I think the response worked very well because it was not as virulent as we had feared it might be. Although that begs another question as to how cautious should one be in any case in a preparedness scenario. But I think that all of that is being quite positive, because we don't know when or to what degree that next pandemic will come through. And it's, from a precautionary principle perspective, it's very difficult to set finite goals that say, well, we'll be ready with vaccinating 10% of the population. That should be good enough because we can isolate them. Many different things come in place. So I think, not to belabor the answer too much here, but I think that we were lucky, and it allowed us to learn. And those lessons, and there are multiple lessons, they're being shared amongst all 3 countries as we speak. And that practice will go on for the next, I'm sure, 6 months to a year, maybe more, to guide how we position our integrated pandemic response for some other event. And I'll put one other point in here. If it is another event that's a bioterrorism event, which almost by definition will be a more virulent and more infectious, or certainly more virulent scenario, and we know that we can create those bugs. We know we can. It's been done in laboratories, research laboratories. Then that system will be really tested. And it's a different dimension then. Not only do you need to have the public health response well defined, but other elements of countermeasures, interdiction, isolation come into play. So, like I said, that was a long answer to your question, but it was not a simple question either.
And I'll just add in, thank you for giving me the leeway to be a bit oblique. But I from perspective of what we've done, my personal experience was having been basically the pandemic person doing a bunch of preparedness work for Homeland Security, and then when the pandemic started, becoming the pandemic person for an active pandemic. There's a certain level of a level of certainty that for which we planned, which didn't happen. As we all know, a health event is inherently uncertain, and there's inherently a level of a degree of bounds of confidence, which can be very difficult to explain to decision makers, because they want to know, well, what's the right answer for what to do here? Should we close schools or not? Should we use adjuvant or not? Should we delay seasonal flu? How does that timing work? And I think we did learn a lot through the last number of months about this. And if you think back through how this began, there was uncertainty about the denominator of the number of illnesses in a population against the number of really ill people in a population, and that drove a lot of the decision making. And then there are the national differences in attitudes and beliefs about certain things. There are issues in the U.S. about adjuvant and issues about vaccine acceptance that influence our national decision making, particularly at HHS, which is not the agency where I work, but the people that have to deal with that as a reality of decision making. So there is science that drives all of these things, including school closure decisions. And if we look back at how we in the U.S. decided on those things, it was very much driven by what we knew week to week that changed week to week, because we learned more and more every day. And I think as we go through this after-action process that we're all doing, we'll be a bit better, and hopefully when a bigger one happens, which that may well happen, we'll be better prepared. I don't know that we'll ever have exactly synchronous actions country to country, but I think all of us have now exercised some of those communications mechanisms.
Good. Thank you. Yes, sir.
Thanks. I'm curious, from your point of view as a panel, what did the pathology of the H1N1 reflect in terms of new patterns of agricultural production in North America? There was discussion about where the disease came from in Mexico, what particular farms, and what kinds of farming methods were involved. And I'm curious to know, especially, what kind of coordination is there in North America in terms of managing livestock and production processes as a region? Do we have the same standards? And what should the North American medical community be saying to the North American agribusiness community in terms of trying to prevent interspecies transmission of diseases like H1N1, and what is being said and done from your point of view? Thanks.
I'll start with that. I'm not an agricultural expert, but I will tell you, I would actually reframe a bit of the question. Rather than asking what should the North American medical community be telling the North American agribusiness community, it really should be a two-way communication and more collaborative, because we all know that there are animal-borne diseases that can affect humans and vice versa. And while we're aiming at H5N1 as a disease of birds, H1N1, at least a version of H1N1, is a disease of swine, but not all H1N1, of course. And I think a better understanding, and it's termed One Health in many circles, as animal and human health really interacting with each other. There are many cases where the animal community and the human community interact very closely and can pass disease one to the other. There are an animal trade, an agribusiness, is inherently international. Things cross our borders all the time. That's a fundamental part of our commerce, and the systems within the countries are not identical, but there's increasing cooperation. But I would encourage, I think we would all encourage, within our office, we have an office of Food, Ag, and Vet Defense Division that works with our human health colleagues to try to do that education and to do that collaboration to see if there are patterns of, for instance, animal disease that might transmit to humans, or just animal disease that could affect animal populations, which are a bad enough economic problem.
Did you want to respond to that?
Yeah, I can. And your point is well taken. And I think it's one of those emerging areas of interest or concern or recognition, maybe that's the best word, recognition, that is guiding a lot of our actions right now. In Canada, what's being done is to bring the three or multiple agencies together in a formalized sense, so that where we have, instead of being reactive to outbreaks, that there is that the gap between identification of a pathogen showing up in a production animal site or food that's been produced from that is, it used to be that then you'd started tracking as to where did it show up as a human illness or cases of human illness. That is being brought more and more tightly together. And in case in Canada, it's a combination of the Canadian Food Inspection Agency, the health regulation side of Health Canada, Public Health Agency, and Agriculture Canada itself, that is trying to stay ahead of the curve, I suppose, in being ready for with better surveillance, better identification in case of outbreaks, and more rapid response. It's not perfect yet. Maybe it never will be, because we are, by way of our food requirements in the world, and doesn't matter where in the world we're talking about, forced into industrialization of animal rearing. And for the most part, it's animals rather than plants that are causing the problems. So whether you're talking chickens or pigs or what have you, industrialization of those increases the opportunity for contamination in the production scenario and therefore spreading out into the world. And the rest of the down the supply chain, well, the circumstance which AVP, right, with HVP at the moment, with in that case a plant protein, we know it shows up in multitude of products. And the recalls that are happening in the U.S. and in Canada right now are just an example as to how complex that particular scenario is and how rapidly something can spread throughout the food chain more broadly, exposing internationally large portions of the population, potentially at least.
Professor Brody, did you want to add any comments on that? No? Okay. This panel a little bit reminds me of one I sat on a couple of years ago with, it was at the American Political Science Association, and it was a debate of Samuel Huntington's Clash of Civilizations with Francis Fukuyama's End of History, Last Man. And unfortunately, Sam Huntington was very sick at the time and didn't show up to the panel, so the panel then presumed to say what they thought Samuel Huntington would say. I don't want to do that, so if there's anybody in the audience from Mexico who would like to contribute your perspectives to this discussion, please feel free to do so. We would like to include that. We don't want to neglect that perspective, so we welcome your comments as well. Okay. Sir, in the back? Mm-hmm.
Carl Eck, Congressional Research Service. I realize they were quite different events, but to what degree did the response or the lessons learned from SARS inform the response to H1N1, please?
I think with SARS, and I can couch this in saying that's before my time with the Public Health Agency, which wasn't even in place at that time. The response to SARS was more haphazard. It was not as well coordinated. It was not as well either nationally or internationally. I think there was rapid recognition of this virulence of SARS, but those very mechanisms that we put into place more effectively with the H1N1 pandemic were really just being tried out in the case of the SARS epidemic. And you know, the organism was different. It had different etiology and so forth as well. But as far as systemically, from a management perspective was concerned, I think we weren't quite as ready.
And I'll just add in, I also was not a government official at the time of SARS, but I'll tell you that I think that and you're correct, that episode was different because the bug is different. But I think there was much more of a public and also governmental recognition that first, we need information faster about things that are going on in all parts of the world, because second, viruses and other pathogens can spread very quickly around the world, primarily by air travel. And I think that was, while that was real before SARS, it was probably seen as theoretical, or maybe that won't happen by many people. But SARS made everybody realize, oh yeah, that really can happen. And I think there was then, in pandemic planning for whichever pathogen causes the pandemic, there was a recognition that we need to think about that, and an assumption, and not a need to explain that we have to think about that.
Maybe could I add on that? This is well outside of my direct expertise, but I mean, as Dr. Englert says, at least in Canada, the Public Health Agency of Canada is a creature of SARS. On the political side, there's no question that although there was, as we say, great theoretical understanding of the potential here and good provincial level or various different kinds of provincial level public health preparations for this kind of public health event, I don't think there was any understanding of the national implications of this or the need for a national tracking and then response capability. I was in opposition at the time. We made hay with that, I'll tell you. The guy you want to talk to about that is Tony Clement, who was the Canadian health minister when our government was first elected and was the provincial health minister in Ontario for SARS. I mean, everything that we sort of needed to know as a government to deal with the H1N1 outbreak was learning really from Tony's personal experience on the provincial side, and I think he'll tell you, I wouldn't pretend to speak for him, but it was night and day.
Good. Yes, ma'am. Mm-hmm.
I am not from Mexico, but I am originally from Colombia. And I make my living by tracking the transnational terrorist organizations, the transnational criminal organizations. And it seems to me that this panel touches specifically on the underbelly of the war on terror all over the world, because there are a lot of chemists and biochemists spread around the world with unemployed or underemployed. And we cannot forget the corruptive capacity that the money of the, call it the bad guys have all over the world. So it seems to me that when a spread of a pathogen comes in, it's more a reactive than a preventive measure. We have to react, and we're prepared to react. But how can we prevent somebody, not only in Latin America, and I have seen the jungle laboratories, and also in China, the laboratories in China for genetic medicines. How can we prevent something like that from spreading or from beginning, so that we don't have to react, that we can be proactive about it?
I think there's that's a very good question, and I think there are some lessons from unintentional disease transmission that can tell us more about that. There are clearly bad people who would like to do bad things, and there are opportunities based on financial realities. Money can be very corrupting. One of the things that through better cooperation between the security and the health communities, which was not always all that great. There history, there are sort of very siloed organizations in general that don't even really speak the same language. And I think, I know in the U.S. and from what I understand, also in Canada and also in Mexico, these sorts of H1N1 and other types of planning allow for improved communication between the security element, which includes intelligence, analysis, and law enforcement, and the health elements, which can then translate those threats into what real effects would be. And so I think that this is also not perfect yet, but needs to be better, and there's a recognition that the intelligence community and the law enforcement community are understanding health threats better and understanding what the consequences of those jungle labs could be on a population. And then the health community, which is not traditionally an intelligence or law enforcement-based community, understands the implication of a threat environment and how the need to plan for those sorts of threats exists.
I don't think I could have said it better, and I agree. And I think as part of, but in addition then, as part of that, is that agencies that have a responsibility for a health response to assure health security also have to be able to do that assessment, that diagnosis, that characterization of a threat on a priority urgency basis. And frankly, I think that's one of the reasons why a public health agency like that one of Canada was separated out from the normal ministerial-driven departmental setting, to be more light on its feet, to be totally operational. And we see the same thing happening throughout North America and throughout most of the world, at least.
Good. Thank you, ma'am. Yes, sir. Professor Kelly.
I've got a lot of words. The SPP pandemic flu paper is of interest for several reasons. One, there aren't a lot of things like it that came out of SPP, something that all three governments agreed was important and that they worked on. And frankly, in the North American context, there aren't too many trilateral governance documents. There's NAFTA, but everything else we've been discussing at this conference is often dual binational. NORAD is Canada, U.S. So that piece of work, while aimed at avian influenza, was interesting. So I know, Dr. Engelhardt, one of your slides kind of tallied up the things we could, looking back on how H1N1 was handled. If we hadn't had that planning document, what would the consequences have been? What would we not have done as well as a continent in managing H1N1, or flipping it over? What did we do much better than we would have done if we hadn't done that planning in the SPP process?
Well, I think I sort of started out, my first question was sort of almost an answer to what you're saying, is that we trilaterally were able to react in a more unified fashion with, frankly, in the case of the H1N1, a very rapid identification of what the problem was. Right? Did it have a chance to go into a pandemic scenario?
And did that occur because personal relationships had been built up in the process of building the SPP plan, or did you already know each other? Were there protocols in that agreement that allowed you to do that identification more quickly, or?
All of the above, in fact. Really all of the above. It built on strengths and put them into an operational framework, response framework, a responsibility framework, in fact, that allowed that more coordinated response.
And I would agree. I think you touched on the relationship issue, and there's the North American plan, but every government has their own plans that require discussion among departments who maybe don't talk together all that often. So part of the benefit of having a plan is to be able to go to sometimes very new leadership, in our case, very new leadership, and say, here's a document that the three countries have worked on, and here's our plan. But the other benefit is the people that actually worked on that all know each other, know how to reach each other, and have built a level of trust that they all are working on the same goal. And that's really the second benefit of having a plan, not the paper part, but the people that actually did it.
And just to clarify for those who aren't familiar, the SPP is a Security Prosperity Partnership that was developed under the previous administrations for three countries. And so that's why the question today is whether that language that Professor Brody mentioned, are we still using that term? But that was one of the products that did come out of a process that was begun back in 2005, I believe, is when that was signed initially, the Waco, Texas meeting. Are there any other questions? Yes, sir. Mm-hmm.
Hi, my name is Matthew Rackety, and I am actually a student at the University of Calgary, so my question will come from a Canadian context, and I'll direct it to Professor Brody and Dr. Engelhardt. Just an anecdote. At the University of Calgary, I have peers who, when the H1N1 pandemic was on the rise, who would refuse to get a vaccine because they thought it was... I mean, some went to the extent that they thought it was a conspiracy. It's really bizarre stuff, but and I know there's a huge surplus, as a previous questioner had mentioned, of H1N1 vaccine, and I'm wondering what is being done to address this issue amongst the public, and trying to communicate to them the importance of these health threats, and what are the implications of this for future pandemics or even terrorist attacks. Thank you.
Well, I must say that even I got tired of seeing my boss's face on television telling me I should get my shots. But it's that flip comment is sort of related to what you're asking. I mean, leaving out the issue that students are a little bit more rebellious than maybe older people in the population. People don't like to get shots, right? Don't like to be vaccinated. The needle is something people stay away from. I mean, when you look at how many people actually get their seasonal shot, it's relatively small proportion of the population. So there is that initial, I can get a sniffly nose and get over it reaction. I don't need a shot for that. So there was a disconnect between, at that time, recognition as to what the potential of a true pandemic might be, and what it might have been. And as I said, we were lucky that it didn't get to be as virulent. I think that the sort of obliquely again going around your question, there's a risk associated with the fact, it's related to communication, but my answer here. The risk associated with the fact that the disease was not as, pandemic was not as virulent, not as problematic, is that whereas we made a lot of precautionary comments and public campaign that urged everyone to be vaccinated. And then we learned along the way that, well, you didn't need 2 shots, and perhaps, we don't know yet, but perhaps a smaller proportion of the population being vaccinated was good enough. That there's a risk of complacency happening in the general population. Now, you told me to get vaccinated, I didn't really need to. And that is a new issue that we have to deal with. And it needs to, in my opinion, it needs to be dealt with relatively quickly. So all the lessons learned exercises that are going on right now, the ones I've seen, have woven into that, those lessons learned, into the evaluation, that question. How do we deal with, now that we got away with it, how do we deal with the reality of that in the public's psyche, conscience, so that should something else come again, whether it's 2 years or 10 years from now, we don't know, from maybe a natural sort of cyclicity of pandemics, and they have occurred in roughly about 10-year cycles to varying degrees of severity. So that's an approach that has to be well evaluated and then brought out to the public. So there's an education component associated with that. With respect to its influence to bioterrorism, I don't think that's really the case. People are, and this is subjective, my comment, I think people are generally scared. Because there is a realization, I think, in the general population that you can do almost anything to create a superbug. And then all it takes is the will and the mechanism to deliver it. And that's, again, in my personal, more scientifically based opinion, that is real. So, that the two are not quite parallel.
Whatever well-known phobias and conspiracy theories there are in the reaction to vaccines and to other public health issues that I think the folks who work in the area are pretty well familiar with. There's no doubt there's an additional level of phobia and paranoia that comes with anything North American. To the extent that I remember when I was with the Prime Minister getting asked at a press conference once about the secret plan at one of the North American leaders' summits to pave a North American highway and a whole new class of highways that would connect Canada, the United States, and Mexico, and how are the negotiations going on this super secret plan to pave over a new set of superhighways. And I laughed, but the Prime Minister sort of laughed, and he said, well, he says that's really a conspiracy theory. I'm not going to really comment about that, but I wish we could get to that. It would be so wrong if we could pave this great system of highways. I think the Prime Minister likes to drive as much as I do. But to the point where, some story gets out there that the leaders are secretly hatching a plan to pave a massive set of superhighways to unite the three countries together, that somehow that's bad. If you can construct a conspiracy theory about how bad it is to facilitate easier highway transportation between the three countries, I think the public health guys have got to worry about the sort of known factor of people who are worried about vaccines. When we layer over the North American side, there's a whole different level of irrationality that comes into that. I don't have a solution to that.
We have one final question. Yes, ma'am, right here.
Do I need a microphone?
Did you? Okay.
There you go. Thank you. Hi, my name is Damini Mohan, and I'm from Alberta, Canada. And I'm doing my internship here at Global Centurion. So my question is directed to Dr. Engelhardt and Professor Brody to comment on. And I'm not entirely sure if this falls under your area of expertise or if it's under Health Canada or provincial jurisdiction. But it's in regards to transmission of HPV and the relation to HIV/AIDS. And some reports that I've read says that people who are infected with HPV are more susceptible to be infected with AIDS virus or HIV/AIDS. And so in Canada, we are vaccinating young girls. but I'm not sure if there's a program which is equivalent to that in U.S. or Mexico. So potentially in 10 years' time or 15 years' time, when we have a set of people who are immunized but from a particular disease traveling to U.S. and Mexico, where we have two other sets of people who are not immunized and they're interacting, how is that a health risk or a problem to the Canadian population, which has taken steps to vaccinate its population, but the other two countries in this trilateral cooperation have not, or that I'm not aware of. So, not sure if I'm pretty clear on that or not.
Let me try. I mean, HPV vaccination, which is currently the only product that's permitted, is for young women, for women, young women. In any case, is not a. There's no campaign of magnitude that says it's put this way. It's much more of a voluntary decision. Okay, the vaccine is available. There is discussion going on whether or not, applications in place for allowing, from a regulatory perspective, having an HPV vaccine for boys and young men as well. But that's it is not a, the linkage of HPV to HIV is really not that clear. And that the social determinants, medical determinants for one and the other are different. They may come together, certainly, and be co-infections. But I don't think it's really so related to your question about travel. That's a very different scenario. I don't think that you're quite on the right track with respect to that question of transmission of disease.
Okay.
Did you want to follow up with that? I mean,
I'm not a medical doctor. I have very little understanding, but I guess did I turn it on? Do I need to turn it on? Okay.
You're good.
Yes, there's no direct interconnection or any study that shows their HIV/AIDS and HPV are interlinked. But I guess digressing a little bit more, it could be that the occurrence of cervical cancer, other sorts of prostate cancer in men, and other types of cancers which do come from HPV. And I know in Alberta, for example, it's mandatory for all the young girls to get it through their junior high and high school. So I guess we're still making, how do I put it? I guess one group of population is vaccinated, but then two groups are not. And I guess I should have this conversation with you later instead of just directly
I think that would be the
in
case.
a panel like this, but yeah.
Let me just couch it in the sense that HIV infection, HPV infection, and related tuberculosis and so forth, I mean, they come together, are certainly issues of public health, but they're not pandemic-type issues that require a type of emergency response and trilateral security-related cooperation that we're talking about in this forum. There's certainly lots of cooperation that's going on amongst countries, among all three countries, with respect to characterization of disease and countermeasures and medical treatment and so forth, but and even the social context thereof. But this is not the forum for that. Okay? Yeah. I'd be happy to talk to you more about it offline.
Okay. That's fine. Okay. Okay, well, very good. I think we're going to go ahead and end our panel there, so please join me in thanking all of our panelists for participating. We'd like you just to stay still. We're going to go ahead and just transition into our closing right now. David will have a few comments to share with us. So we're a little bit ahead of schedule, but on a Friday afternoon, I'm sure that's okay.
Actually, not very many comments, but I think it's been a really fascinating day. I think this program today demonstrates what we do at the Wilson Center, which is dialogue. That's the name of our television and radio shows, and really what we believe that policy people, academic people, and general folks interested ought to talk to each other to learn more about what's going on. I think our dialogue on national security, cooperation in the military, police and public security, and this last panel on public health and public safety, it's all very important to see how we've come together, our three countries, what remains to be done, and what even might not need to be done. But I think that with a lot of pre-planning and the knowledge that's been going on, we've actually learned a lot. I think David Heyman at lunch today was interesting. He turned and asked us a lot of questions. What would we like to see? What would we like to do? And in my conversation with him afterwards, he said, I'm really serious about that. So I think he's expecting to hear from us comments, questions, how we might improve things. Special thanks to our colleagues who traveled from Mexico. Muchas gracias. And those from Canada as well. And to my Mexico Institute colleagues here at the Center for partnering us on this. And to the Virginia Military Institute for their genesis of this, to General P for bringing his support and for bringing along the cadets. We really appreciate that help. And to Todd Hatley, who had to leave, and to Abelardo Rodriguez for your plans, along with Rick Kilroy, and getting this together. I think it was a really great program. I think there's going to be continued conversation. As we said earlier, the video will be posted soon. We have to sort of mix it, and we want to divide it up into panels so that you don't have to watch the whole thing to get to this one. We'll also post as many of the ancillary documents as well on the website, and if you have other articles that are related, please send them our way, because we'd like the website to be a reference document for people to use for continued conversation on this. So enjoy your weekend. Mind the rain if you're going to be here. Thank you very much. It's greatly appreciated, and we hope to see you here again. Thank you very much.
Thank you.